Good morning, good afternoon, good evening, clinical problem solvers. Nice to see everyone. It's Tuesday, every so often, neurology morning report. So hope that's okay with everyone. If you knew this was neurology morning report and are excited for it, welcome. If you thought this was going to be some case of hyponatremia, well, also welcome. And there may be some hyponatremia and some neurologic diseases. So that could be interesting too. So wondering if anyone brought a case this morning, a neurology case. Please, not a case of hyponatremia unless there's some neurologic things to go with it. And we would like two participants to discuss that case, ideally one identifying as a woman and one identifying as a man. Anyone brought a neurology case that they wanted to discuss? And anyone like to discuss that case? Valeria has a case. TB or not TB? That is the question. Had many excellent TB cases from Valeria, but you never know. Who would like to discuss Valeria's case with Valeria and myself? Someone saying it's their first time here. This is informal. If it's your first time and you'd like to discuss a case during your first time here, you're more than welcome to. It's informal, fun, and for learning. If you want to just watch, listen, that's fine too. Sure, great. Okay, we have one. And anyone else like to? Joy, fantastic. Anyone else like to discuss with Joy, Valeria, and myself? All right, maybe Valeria and Joy, if you want to introduce yourselves, tell us where you're calling from, and then we'll see if someone else chimes in.
Hi, it's great that we have Neuro VMR back. Hi, everyone. I'm Vale. I'm calling from Lima, Peru. I'm currently recovering from COVID, so my voice is a little off. But I'm really excited to share this case with you guys, and it's going to be an amazing discussion, I'm sure.
Fantastic. Well, thanks for joining us. Hope you're feeling better. Joy, do you want to introduce yourself? Oh, you might be muted, Joy.
Hi, can you all hear me?
Yeah.
First of all, I'm a huge fan of yours, Dr. Berkowitz. I've been following Neuro VMR. I can't thank you enough for what you're doing here. I'm obviously a medical trainee applying for neurology. So I'm doing a clinical rotation here in New York. So I'm in New York. It's mostly TBI cases that they're seeing. It's a really hectic, like they see like 40, 50 patients a day. The neurologist has like 3 assistants and yeah. I'm the last one to come here in my family. But I did all my education in the Philippines, in Manila. So yeah.
Okay, welcome. Thanks for your kind words and thanks for joining us. Anyone like to discuss this case with Joy, Valeria, and myself? Anyone?
Same. Thank you. Thank you. You guys are so nice.
Oh yeah. Anyone else like to join? Anyone? We don't have too many Neuro VMRs.
I feel like I should let somebody else do it as I'm an attending physician and I'm on my lunch break.
Oh, well, you're more than welcome to. We've had attendings discussed also. If you'd like to, if you think you'll get interrupted or would like to eat your lunch in peace and watch a spectator sport version, that's totally fine too.
Yeah, I probably should just watch.
Okay, sounds good. Anyone else?
Hey, Aaron, Mattia. I'm a resident, but if you guys don't have anyone else, I'm happy to chime in.
More than welcome. Now, all of a sudden, we have lots of people chiming in. I think, Yasmin, you've discussed, well, not that recently, but several times, right? And Hans as well. So I think, Mattia, it's been a long time if that's okay. We'll have Mattia, do you want to, I know we've met at the AN and here a long time ago, you either presented a case or discussed a case or maybe both. Just want to quickly introduce yourself and then we'll get rolling.
Absolutely. And now I'll turn my camera on momentarily. And full disclaimer, I'm also recovering from COVID. So I was planning on just hearing this from my bedroom, but I'm happy to chime in. I'm a PGY3 now at the Medical University of South Carolina. And yeah, these are always a highlight for me.
Fantastic. Well, happy to have you. Sorry you've had COVID. It seems everyone is getting it now for the first time or again. And hope you're recovering well and all good. Yeah, and as Maria said, I was thinking the same thing. I think you were either an intern or just starting neurology residency last time we had you on. So time is flying, and before we know it, you'll be in attending, and we'll be excited to have you join us. Okay, great. Maria, do we have folks to do all the other things? Great. Okay, so Valeria, do you want to give us just the chief concern, and then we'll go ahead and get started.
Yeah, so the chief concern is headache and altered mental status.
Headache and altered mental status. So Joy, when you hear either one of those concerns and or both of them together, what starts running through your mind?
Well, I definitely I would first think of primary headache etiology here, being that this is a Neuro VMR, but obviously you have to rule out the systemic causes, right? Like if you know, toxins and you know, the electrolyte imbalances that could be, but you know, headache, my mind goes right away to primary headaches and secondary headaches, obviously, like and there is also the altered mental status there, and yeah, I would definitely think like as far as like, is this something chronic or this is just something abrupt, you know? Yeah, that I would, yeah, that would be my starting point, like the chronicity and yeah.
Excellent. This is great. So just sticking with headache for a moment, you mentioned primary and secondary headache disorders. Just for others who might not be familiar with those terms, Joy, can you define what you mean by primary and secondary headaches?
Well, primary headaches are the one that like, you know, the most common that brings people to a neurology office would be migraines, right? Like it's around like 90% of the time. Obviously it's kind of biased there because like, yeah. And the other ones are cluster, like the cluster tension headache, the headaches that obviously not caused by, we can't pinpoint other, you know, cause for them. Like if you would say secondary headaches, like trigeminal neuralgia, there is something like you can point to, like as a cause of them having the headache. So yeah, that's what we mean by secondary versus primary headaches.
Yeah,
like
perfect. Oh, sorry, go ahead. I didn't mean to interrupt you.
No, I'm done.
Okay, great. That's perfect. Yeah. So the primary headache disorders are the disorders that they must have some cause, but we haven't elucidated it yet. So we call them primary, and that includes migraine, tension, cluster, and then cluster is part of a larger umbrella of trigeminal autonomic cephalgias that have cluster. Itself is actually very rare, though it's common on the board's exams. It's not very common. And then there are even less common headaches in that category, Sunct and Suna and paroxysmal hemicrania and hemicrania continua, all these that have sort of a description but don't have a particular biomarker yet. And it's still important to distinguish one from the other because they respond to different preventative and abortive treatments. And then the secondary, as you said, are headaches where we can identify the cause. And I usually break those down into headaches caused by problems in the head, of the head and neck, or systemic. So in the head, anything that can affect the brain, meninges, vessels, ventricles, can cause headache. Anything that is of the head, so anything as mundane as eye strain or sinusitis, or a dental problem to some very serious, orbital cellulitis or glaucoma or any of those structures of the head, right? Not in, but of the head. And neck also, right? Because neck pain can be referred to the head. There's so-called cervicogenic headache from cervical degenerative disease, carotid and vertebral dissection pain can be described, headache in some cases. So neck pathology, and then systemic pathology, right? Those of you who have had or are recovering from or received the vaccine for COVID, right? There's often a headache with it. And I always wonder, what is that? Headache, is that just from cytokines floating around or some mild irritation of my meninges? Hopefully not. Or is it just dehydration, or what is it? But headache can also be caused by systemic conditions. So great. The headache, we're thinking primary versus secondary, and then the altered mental status, and the headache as well to some extent, right? You mentioned the time course, which is very important. Some people like to use mnemonics for this, MIST and others. I always find mnemonics very hard to remember what things stand for, unless the mnemonic and the symptom are sort of the same. Even then, is the I inflammatory, iatrogenic, idiopathic? What is the I? Is the I the second letter? Where I find them very difficult. So I like to organize things as you did, Joy, by the time course and ask, is this sudden onset? That would make us think of a vascular cause or epileptic cause or trauma or some toxic ingestion causing confusion. Is this acute but not sudden, so fast but not instant? Is it some type of neurologic infection or inflammatory process? Is it subacute, making us think maybe of something neoplastic, although some inflammatory or infectious conditions can be subacute as well, such as fungal or TB related or parasitic infections? Or is this chronic change in mental status, which might make us think of something degenerative, although these are just rough rules, and many exceptions, and toxic metabolic etiologies are sort of in the differential for all, as you mentioned, with electrolyte dysfunction. So now turning to you, Matthias, as a neurologist here. So we've talked about an approach to headache, just a very broad brushstrokes. We talked about an approach to altered mental status. What's running through your mind when you see these two things together?
Yeah, no, excellent discussion. The first thing, the system one thinking, that makes me jump to is kind of, first of all, thinking about what the setting is, right? Because if this were an ED consult, an urgent ED consult, and someone presented with a headache, and then they had some disturbance in their level of arousal that was hyperacute, I would definitely be thinking toward something vascular, like a subarachnoid hemorrhage, for instance, or an ICH. On the other hand, if it was more on the acute side of things, we see this a lot, I would jump toward something like meningitis and encephalitis, but that's more like sort of the type 1 thinking, right? And this would be a completely different story with regard to whether this would be a patient presenting in my clinic with a chronic headache and, altered mental status. And I think a lot of this, going more toward a layered and thoughtful approach here, I think a lot of this also has to do with what we mean by altered mental status. And I think that we may mean a bunch of different things. We may mean disorders of arousal, where someone may present with difficulty in rousing. So we may be dealing with someone who is stuporous, or may be dealing with someone who's somnolent. And what that really means is, how easy are they to wake up? First of all, are they awake, alert? Or are they falling asleep and then waking up, which would make us think of drowsiness or somnolence? Or finally, are they arousable only to pain, where we're dealing with stupor, or are they not arousing to anything, in which case we're dealing with a coma? And in that case, really knowing the trajectory of the headache and then a disorder of arousal would make me go toward, if it's hyperacute, again, probably something vascular. And it could be both a bleed, as we said, a trauma, importantly, And finally, of course, in ischemic stroke, although those don't present with the headache commonly, of course, there are plenty of exceptions, especially with, I mean, one can think of plenty of exceptions with the thunderclap headache causing a dissection, but you know that's a whole other conversation. But I think really knowing the time course is key. And again, then going toward other buckets, you know, thinking about acute, thinking about the setting, you know, is this someone who's febrile, which will make us think about meningitis, encephalitis. We know that the Kernig and Brudzinski sign are beloved, but imperfect, of course. And finally, you know, if we were to go toward episodic, subacute, and chronic, we probably be dealing with something else. We've seen, I don't know your guys' experience, but we've seen patients with very severe migraine who looked confused, and we went down the meningitis rabbit hole. And finally, of course, toxic metabolic is always a mimicker of plenty of things. Now, that's for arousal. If we're dealing with content of consciousness, then we may be dealing with something completely different. And that could be something space occupying. Of course, you know, I kind of didn't mention something like HSV encephalitis is also possible, of course. But yeah, I mean, it's really about knowing the time course, I think, knowing about what the trajectory is from the headache, how the headache started, whether it's a thunderclap headache that started within seconds, and of course, knowing what the setting was in terms of, is the patient febrile, is the patient hypertensive, do we have any risk factors for PRES, is the patient immunosuppressed? Those are just some of the thoughts, but it's a really, really rich chief concern.
Yeah. Someone pointed out, reminded us about the SNOOP mnemonics. I think that's a very, a quick run through that also reminds us of the red flags. It's a very good mnemonic. The 2 S's, the systemic causes, structural, the neurological that points us to something vascular, and the older age, right? If this has been if they were having headaches episodes before, or is this like a change to the severity of their headache symptoms, you know, that's kind of a red flag. And obviously is it like positional, or those other things. And as far as like you mentioned about migraine, I learned recently from I listen to a lot of podcasts, and it's a neurology review podcast, and they share something very interesting, that the pattern of, like, especially talking about headaches, migraines with aura, there is this we know now that there is this cortical spreading depolarization, that pretty much the physiology of aura in migraine, that would explain the cortical spreading is from the the occipital cortex going anteriorly. So that sort of explains the visual aura that people with migraines tend to have. Then it could spread. Obviously, what comes next after the occipital cortex is a temporal, that then that would definitely explains, like, some people having this sensory symptoms, and like hemisensory dysfunction, and then it could spread further, right? Like to from the temporal to the parietal, then you and then that would explain the more worrisome visual and language. Some people language, like there was this famous case of a news reporter, right? Like most people thought that they had a stroke right on camera, and it turned out to be a migraine that she had. People talking, I like his point that he said that the people think of there is such a thing as migraine, complex migraine, but with all this, there's confusing that they have this some sort of hemiplegia, but then you would have to dissect that if it's an actual true weakness, or it's just some feeling of heaviness, because like this spreading cortical depression doesn't rarely cross
Great. Yeah, this is
really,
great. I just want to pause you there for a second, just so we make sure we can hear some of Valeria's case, because we're getting a little bit into the weeds of the pathophysiology of migraine, which you as a future neurologist and Mattia and me could talk about all morning, which is great. But I want to make sure, we want to make sure we get to hear Valeria's case. But that was a great discussion, Joy and Mattia. And so just to highlight some key points, right? Mattia mentioned here, right, how important context is, although context can trick us sometimes. So if this, I think what you mean to say is this an emergency, the patient is coming and these symptoms have come on suddenly or over days, is very different than in the clinic and coming for months to years, though sometimes patients come to the emergency room for something that's not acute or to the clinic for something that is acute. And I'll sometimes ask my residents who are ordering a lot of studies in the emergency room, well, hold on, if you were seeing this patient in the clinic, would you have sent them to the emergency room and done all these things, right? So sometimes context is helpful. And I think what you mean there is coming back to our friend, the time course, which is going to help us. And also to highlight, when we talk about altered mental status, we get, as Mattia knows as a resident, probably 9 out of 10 consults, right, are for this chief concern. And what does it really mean? And you divided that nicely, as I like to do, into level of consciousness and content of consciousness. Is this a patient who is somnolent or having difficulty maintaining their arousal, or they're awake, or when they are awake, there is some cognitive modality that's affected, right? Is a patient inattentive, which could lead to confusion? Some patients with amnesia seem very confused, and when you tease it apart, you see, oh, this is actually amnesia, and they're confused because they're not recording any new memories, right? And could it be aphasia? Some patients with aphasia, people think they're confused. So again, digging into whether this is a problem with level of consciousness or content of consciousness, by which we mean sort of the cognitive modalities we usually think about most commonly: attention, memory, and language, though there are others that can give the appearance of confusion. And then thinking of the Venn diagram of these, as you said, if this happened all of a sudden, it's hard for us not to think of something vascular. We don't really think of seizure per se causing headache, though there can be postictal anything, and headache could be part of that. There's postictal nose wiping and ictal spitting and ictal crying and all these interesting things that can happen during a seizure. If this is over days and not weeks, as you said, we'd have to be very worried about meningitis and encephalitis. And coming back to what you said, Joy, headache plus the altered mental status, already we have a red flag there, right? And if this is subacute chronic, then we have other things to think about. As Mattia's resident reflexes here, right, are wondering urgently, do I need to do anything, right? If this is the emergency room and this is minutes, hours, or days of symptoms, what tests might I need? But so the time course is going to be very informative here. And I think after this excellent discussion by Joy and Mattia, we are ready, Valeria, to hear a little more of the time course. And maybe you can tell us the history and anything else in that first column you'd like to reveal up until the exam, and pause there if that works for you.
Yes, perfect. So this is the case of a 52-year-old female, right-handed female, that had 3 months ago the recent diagnosis of not Hodgkin's lymphoma. Since then, she's been having some chronic occipital predominant headache. However, 1 week before admission, this headache became of her whole head and increased in intensity. 6 days before admission, she went to the ED, but they didn't really admit her. It was something that they did wrong because she had the diagnosis of malignancy. But anyways, so the headache got worse and she started having nausea and vomiting and also some dizziness. And the day of admission, the whole week, her daughter noticed that she started becoming more somnolent, started sleeping more hours during the day, and she eventually could not recognize her daughter and started talking words that didn't make any sense. So that's why she was admitted. in her past medical history. She had a diagnosis of not Hodgkin's lymphoma, of primary cervical giant B-cell lymphoma with high risk because the bone marrow was infiltrated. She was diagnosed 3 months before and had 3 courses of chemo, and the last course ended 2 weeks before admission. She denied any other diseases, and what else? She denied any fever, any weight loss. She was diagnosed just because it was a little weird diagnosis. The family said that she had some weakness in her legs, and that's how she was diagnosed. And she couldn't walk after she was first admitted to the hospital after she was given the lymphoma diagnosis. But we didn't have her records from that admission, so we really couldn't know. And the patient, of course, was not in the best shape to tell us what happened. Family history, it was unremarkable. Social history, no alcohol, no tobacco. Health-related behaviors were not contributory as well, and she had no allergies.
Excellent. So let's see. Joy, do you want to tell us what you're thinking now based on some of this new information?
Yeah, I'm thinking, I'm inclined to think that this is something secondary, or what's happening now, because they like some sort of adverse effect of the chemo. That's the like they just had a round of chemo recently, and it sounds like to me like a meningeal process or something like that. I mean, some yeah, chemo drugs can cause a lot of neurologic adverse effects, side effects. So that's my first kind of knee jerk here. So
yeah, that's an important one. Yeah, so let's put that on the list here as a possibility of something related to the chemotherapy. Mattia, what's coming to mind for you? And then I'll share some thoughts also, and we'll get into the hearing the exam.
Yes, I mean, so much in that we have so let's talk about the course, right? So we're really talking about a progressive headache, subacute in trajectory that got worse and went on from involving the occipital lobes to then, or the occipital region rather, to then involve the whole head, to then involve a disorder of arousal. So I think when I think subacute, I mostly think about either subacute infections, which can be fungal, can be something like TB, some viruses can also present that way. And then we have inflammatory disorders. And finally, we have tumors and toxic metabolic too, but something about her history though here is key. We have someone who has non-Hodgkin lymphoma. So by definition, they are immunosuppressed. They're also on chemotherapy, so they're even more immunosuppressed. So that, I think, makes us even more worried about something space occupying, first of all, related to the immunosuppressed state, and but by that reasoning, infections come to mind. That would be a big one. And if we're thinking about subacute infections again, depending on where the region of the world we're at, fungi do come to mind. Then another thought, of course, is also that chemotherapy specifically can lead to both the tumor itself, both the lymphoma itself and the chemotherapy can lead to a hypercoagulable state. So another thought would be something like CVT, which of course would explain the headache, and then would explain a bleed, which would explain a space-occupying lesion. A bit fast. My third thought is a thing that would be a bit fast, but it could be localization of the lymphoma to the brain. I believe that could be possible. And interestingly enough, when I heard originally the occipital headache then leading to a holocephalic headache, it kind of made me think about PRESS too, which of course can lead to obtundation in some cases. And of course, we know that it's associated with multiple chemotherapies like tacrolimus. And last thought, I promise I will not take all the hour, but the last thought is also that, of course, whenever dealing with someone who's immunosuppressed, although we go on to think about the most obscure causes of infections, at least in our side of the world, common infections like streptococcus end up being the most common, although it would be a bit slow for streptococcus. But I'll stop there. There's so much to say, but I'll stop there to allow some discussion.
There is a lot to say, and both of you had some great thoughts here. So putting them together a little bit, one of my mentors liked to say if there was a neurologic symptom in a patient with cancer, the first 10 things on the differential diagnosis are the cancer. And yet we have to be careful of being anchored and prematurely closing and saying this is a complication of the cancer, because patients can still get other conditions. But gee, I agree with you, it's hard to tear ourselves away from that very important element in the history here. So how can cancer affect the nervous system? I divide that into 3 broad categories. One is there can be direct involvement of the nervous system, such as a brain tumor or spinal cord tumor or metastases, which are more common to nervous system structures, or tumors in areas that are compressing neurologic structures. So direct involvement is one. The second, as Joy mentioned, is complications related to treatment. So chemotherapy can have all sorts of neurologic complications. Mattia mentioned PRESS. Peripheral neuropathy, obviously not on the table for this case, with headache and altered mental status, very common complication of cancer chemotherapy. There are radiation toxicities to the brain cord, plexus, et cetera. And then the newer checkpoint inhibitors, CAR T-cell therapy, a whole sort of field of neuroimmunology is evolving around all of the complications that can be caused, neurologic complications that can be caused by these treatments. So that's sort of category 2, chemotherapy, radiation therapy complications. And then category 3 are paraneoplastic syndromes, of which the list continues to grow, in which some type of immune response to the cancer generates neural autoantibodies. And I would sort of add roughly in that paraneoplastic category, something Mattia mentioned is just the hypercoagulable state of cancer, Trousseau's syndrome, which again, one of my mentors, I think some of you have heard Marty Samuel speak about Trousseau syndrome, that it's a true apostrophe S because Trousseau both discovered the syndrome and died of his own syndrome that he diagnosed in himself when he developed a DBT related to what was ultimately gastric cancer. So sort of in that field of cancer related is sort of hypercoagulability. And then you have the additional factor here, as Mattia mentioned, that the cancer itself and the chemotherapy are immunosuppressing this patient, which puts the patient at risk for all kinds of infectious complications. So you were trying to use, Mattia, the time course here. So if this is really going on for over a week now, I agree a bacterial meningitis would be less likely. Strep or Neisseria, the patient would probably not survive for a week without treatment. So does this patient have a space-occupying lesion that could be infectious, cancerous, or chemotherapy related? We wouldn't think of PRESS as necessarily space-occupying, though it's edematous, though it can be when severe, or a hemorrhage, or a stroke, or something like that. The course here is sort of progressive, so something vascular seems a little less likely. And I think the other thing to think about in terms of localization is, if we'll see on the exam, but if there are really no localizing features and we just have sort of headache and somnolence, nausea and vomiting, whether we're seeing a rise in intracranial pressure here, which I believe we are and has been mentioned. Mattia mentioned the possibility of a space-occupying lesion. Let's just remember that intracranial pressure can rise, 1, due to problems in the brain, 2, due to problems in the ventricular system, and 3, due to problems in the vasculature. Those are the 3 intracranial compartments, 80% brain, about 10% CSF, and about 10% blood. Mostly that blood is in the venous system. So a mass could raise intracranial pressure. This patient could have hydrocephalus. Maybe they have a meningeal infection. Maybe they have meningeal spread of their lymphoma to the meninges and have developed hydrocephalus. And then a venous sinus thrombosis. I don't think of lymphoma per se as a condition that's going to be causing hypercoagulability and a venous sinus thrombosis per se, but progressive headache, progressive decline in consciousness, that's one of the things one could think of, because the patient would develop sort of cerebral edema, and unless they have a hemorrhage or stroke related to that venous sinus thrombosis, they may not have a focal lesion. So I think one important aspect of the exam is going to be seeing if there's anything focal here. We're dealing sort of with a global encephalopathy, or if there's anything focal. And so, yeah, so let's hear the exam. And yeah, let's hear the exam and go from there. I have lots more thoughts, as I know Mattia and Troy do too, but we have to get some more data here. So I think we're still wide open. Is this cancer affecting the brain or meninges? Is this some complication of chemotherapy? Is it a sort of also sort of indirect complication of chemotherapy causing immunosuppression, causing some type of infection? And is that in the meningeal compartment, or is that in the brain parenchyma itself? Paraneoplastic, this is a little fast for that. And there's a headache, which I don't really associate usually with paraneoplastic. So I'd probably put that lower. So we're sort of, I think, leading now with cancer or infection due to immunosuppression as we go into the exam. So let me just ask you, Mattia, since you're in a part of your career where you're examining hundreds, if not maybe close to 1,000 patients per year. And so by the time you finish a history, you probably have a hypothesis already. Do you think you're going to find anything on the exam that's going to take you further towards a diagnosis? We all know that there's going to have to be imaging of the brain in this case. Is this a case where you're sort of doing the exam to make sure, but eager to see the imaging, or going into the exam thinking there's clues here that are going to help me figure this out?
You know, with the fact that we're suspecting increased intracranial pressure, and we have this differential of whether there's something space occupying or not, I think that's definitely something I would be looking for. You know, any kind of suggestion on the exam that there is some focality to this, whether it's just the patient being less briskly reactive to pain on one side. Of course, I'm not still too sure what kind of mental status we're going to see. I think we're going to see something in between obtundation and coma from what I've heard so far. But of course, if we were to see something like a blown pupil, for instance, cranial nerve 3, compressive cranial nerve 3, right? Or any kind of ocular, and really any kind of cranial nerve, focal cranial nerve deficit that would make me want to lean to one side or the other. And of course, again, any kind of difference in the motoric response. I think that would really give us a good yield. If we were to see no focality to this, then we'd go in another direction, really. You know, it could be something like meningitis, of course. But then again, you know, I would be really curious to see whether there's anything space occupying at this point. That's where I would go.
Excellent. And what is your... Yeah, go ahead. Sorry.
Yeah, and no, the last thought is, of course, like looking at the vital signs, right? So if we were to see any specific pattern to the breathing itself, that could make us go toward a specific level in the brainstem, agnostic versus ataxic. So I think those would be my thoughts.
And let me just push you a little bit, just to ask you sort of your instinct and intuition. Obviously, if you had been taking a history, you'd been looking at the patient the whole time. We don't have that luxury in this exercise, but your intuition, are we going to find something focal here, or sort of a non-focally somnolent patient plus or minus papilledema? What's your instinct? Just is this going to be a focal exam and revealing, or going to be a non-focal and unrevealing exam?
I'll say this: when I heard originally headache and altered mental status, my first thought was meningitis, and then with the whole history of someone being, you know, immunosuppressed, I'm more and more going toward this being sort of a subacute meningitis secondary to the immunosuppression. But I usually like to stay pretty broad with my differentials, but that's where I would go.
I agree. Yeah, always good to stay broad. And I think it's helpful to enter the physical exam with some hypotheses and intuitions, as also when we look at data, although those can also anchor us, right? And it's hard to pull away from initial system one thinking, as you said, the sort of thinking fast. But I think it's helpful to have these hypotheses because then when we're testing them, if we get surprised, they have a certain valence, right? If we go in and I'm sort of thinking based on what we've heard and the things we're considering, that we might not find too much on the exam that helps us further. But if we do find something then, and I have that thought in mind, then it's in a way more striking, although I'm also putting myself at risk for saying, well, the reflex are a little bit different, but I'm not gonna. So I appreciate your metacognition here, right? Saying, well, I'm thinking this, but I have to be careful in case that, but I still like to always push when I'm, on round saying, okay, we all agree to order an MRI. Who thinks it's really going to be abnormal, right? Are you doing it to rule in or rule out? Because if you have an instinct and you see that your instinct was correct, you get a little point in your temporal lobe of my instinct in this case. I learned something. And if you're wrong, you also get a point in your temporal lobe or wherever saying, wow, I have to think next time that I just went down this pathway of thinking this obtunded sick patient is not going to have anything on exam, and I'm going to need an image. And then when we talk about the image also, actually, you get to the point where you think, don't think we're going to see anything, but I agree we should get it. And you do see something and say, where did I go wrong in my logic? So I think helpful to have these hypotheses as long as we're not attached to them, but that is a tricky dance in our minds, isn't it? Okay, Valeria, so tell us, what, if anything, did you find on the exam?
Sorry, I just received a call.
No
I'm
problem.
back. Okay, so the vital signs, her blood pressure was 100/60. Her heart rate was 65, respiratory rate 20, temperature 37 degrees. She was saturating 98% on room air. So initially, well, on general appearance, she seemed acutely ill. She was lying down. She had some dehydration and paleness, but otherwise her respiratory and cardiovascular exams were remarkable, as well as her abdominal exam. On her neurological exam, she was somnolent. She was disoriented in time and space. And when I examined her, she was very fluctuant in terms of her orientation and the evaluation of her superior cerebral functions, because sometimes she could answer my questions, sometimes she just will look away and not answer, or it seemed as if she couldn't hear me, but she would come back and apologize, and it was very fluctuating. So when I examined her, so that made really hard to examine her, but her language was okay. She could nominate, repeat. Her language was fluent when she was able to talk, and she also could understand what I was saying. But I could not examine a lot of like calculations and judgment. Sorry. Okay, so then on the cranial nerves were normal. She did have some bilateral papilledema on the eyes. Then the motor exam, she did have some generalized weakness, but no focal weakness. All four extremities were 4/5, and reflexes were +2 throughout. Her muscular trophism was normal. She didn't seem to be hypotonic or hypertonic. She didn't have any ambulatory movements, and she didn't have Babinski or Hoffman or any Babinski like reflexes. And she didn't have any changes in sensitivity. She did have knuckle rigidity when I examined her, and also on admission. I didn't see her on the ED, but they did report that. She didn't have Kernick or Brudzinski. She didn't have any signs of frontalization. And when I examined her, she did have some Laseg and Bragard signs, which were a little off, but I was not so sure about the correlation of that and, the classic correlation of those signs. And then, well, the coordination, like she didn't have any dysmetria or diachocinesia, and we couldn't examine her walk or Romberg because she couldn't come out of the bed. And yeah, that's basically the neuro exam.
Fantastic, detailed neuro exam from Valeria, and very wonderfully presented. So Joy, let me ask you the question I asked Mattia to predict before this exam, and now we have a lot of information here. Is this a focal exam, a non-focal exam? Does it lead you in a particular direction, Joy?
Well, I was hoping the cranial nerves would, do that for us, but it's normal. And except for the papilledema, which is we know already that she should have. We know that she has increasing intracranial pressure. No, the the physical exam is equivocal. So
yeah, excellent. Right. So in neurology, we love the physical exam, and we love to spend a lot of time at the bedside teasing things apart if we're trying to figure out what is the cause of this facial weakness, what is the cause of this diplopia. But in some cases, we have so-called non-focal exam, or an exam that doesn't really tell us the location beyond this is in the brain, right? It's not in the peripheral nerves, muscle, neuromuscular junction, spinal cord, etc. And so that's right. We knew the intracranial pressure was going to be elevated. We've proven that with the papilledema, and that also tells us that it's been there for some time, because papilledema takes some time to develop. And we also sort of knew that from the history. So this was a sort of hypothesis confirming exam rather than a hypothesis changing exam, although we did find some neck stiffness, which is going to increase our concern here for some meningeal process. Now, Mattia mentioned the excellent point earlier. We all learned Koenig and Brzezinski, and I know I said I don't like mnemonics, but people reminded me to remember that Koenig has K. That's the one where you have the knee flexed and then extend it. So K for knee, and then Brzezinski is bending the neck. And there's a nice JAMA rational clinical exam series. I love these papers where they look at sensitivity and specificity of physical exam signs. And the one for meningitis says that Koenig and Brzezinski signs are something like 5% sensitive, even though they're very highly specific. Why might that be? Well, if you work in a very high resource place where people can get to the clinic, emergency room, or hospital within a day of their symptoms, and they present very early with bacterial meningitis, they might not have developed these symptoms yet. But if you work in places where it takes people a long time to come to the hospital due to difficult access to a healthcare facility, and in places I've worked like that, you see a lot of Koenig and Brzezinski signs, actually, because patients are coming with very advanced disease, either due to limited access or due to their situation that makes it hard for them to get to the hospital until they feel they're very sick and need it. So I suspect in Koenig and Brzezinski signs that not everyone was getting to the hospital within a day of their symptoms. And so these were important signs for Dr. Koenig and Brzezinski whenever and wherever they were practicing, but definitely nothing to hang your hat on now unless it's step one. So we need an image here. And so I'll ask the same question I asked before the exam. What are we going to see on this image? We have now does one of you want to give a problem representation and then tell us what type of imaging you would get and what you'd be looking for? Either Joy or Mattia can take one or both of those questions.
This is I'll try for the problem representation here.
Excellent.
A 52-year-old female known to have a giant B-cell lymphoma, recently had three courses of chemo, presenting with headache and altered mental status.
Excellent.
Yeah.
Oh, sorry. Go ahead. I didn't mean to. What were you going to add at the end there? I think that's my representation here. Yeah.
Awful.
That's great. Problem representation. Probably the only thing I would add is with 1 week of those symptoms, right? Because that tells us the time course.
Yeah.
So with that in mind, and we might also add with nuchal rigidity on exam if we were including the exam there. But yeah, this is just So Mattia, what imaging study would you order, and what are you expecting to see or not see?
So I suppose it really depends on what kind of resources we have. Because to be honest with you, if I was in my institution and this was an ED consult, I could get an MRI with and without contrast and an MRV. Now, whether that's the most parsimonious use of resources, I don't know. But the reason to get an MRI brain with and without contrast is to get a good look at the meninges, especially in this setting where we're thinking, could this be some kind of infectious leptomeningitis? And then if that, that would be a way to prove our hypothesis, and then also to rule out anything space occupying, although our exam has in fact ruled it out already. MRV would be, I've been burnt in the past thinking, oh, increased papilledema without any other symptoms, it's probably IIH, but still we should get an MRV just in case, because you cannot call something idiopathic without ruling out the other causes. And in fact, that gentleman ended up having a CVST, so a cerebral venous sinus thrombosis. By the way, not that I'm advocating this is in any way IIH, no. But now, if an MRI wasn't an option, then we could go with a head CT. And I think the reason here, correct me if I'm wrong, but the reason here is that we really have someone with increased ICP and altered mental status, which would fall into which would be a requirement for us to image the patient before doing an LP, which would be our next step. So this combination would demand imaging. So I think in short, if I were to have all my tools, I would want an MRI brain with and without contrast.
Yeah, I agree with you. Yeah, MRI is going to give us more resolution, and that contrast is going to help us image the meninges here, which are interesting to us. You said our suspicion for a space occupying lesion is low. I would probably just slightly, I know what you mean. I would say one in a eloquent area of the hemispheres or posterior fossa structures is probably low. There could be a mass lesion in the ventricular system, right, causing hydrocephalus. So there could be space occupying, but not the usual spaces, right, that we think of intraparenchymal. But I agree. I think if I was going to guess, and I always like to do this, not as a game or, but, on rounds to say, we're going to get this MRI, what are we going to see? And again, both because if you confirm it, you say, okay, my history and exam and hypothesis really led me down the right track here, and you file that away. Or you say, wow, I definitely wasn't expecting to see that. I need to add this one to my sort of developing concept of what one could see in this situation. And as Mattia talked about getting burned, I mean, this venous sinus thrombosis is a good one that you could miss on imaging without contrast or MRV. There are subtle signs you can see even on a non-con CT scan, but they're not always there. And so there are things that by missing them and someone else finding them or finding them in a different way, these help us develop our problem representations going forward. So I agree, MRI with contrast. And what do I think we're going to see? I think we are going to see meningeal enhancement, and that we are going to see hydrocephalus, and that you're right, Mattia, of our 4 most common tests in neurology, MRI, LP, EEG, and EMG, probably the second one to really make a firm diagnosis here if it's we think it's safe based on the MRI, and we don't have an obvious answer as a lumbar puncture to try to distinguish between infectious and meningitis and leptomeningeal involvement of this lymphoma, because for infections, this really could be anything. I think you've mentioned before, it's a little long for bacterial, but could really be any, fungal cause depending on the patient's exposure history, could be tubercular as well. And there's not going to be any real specific imaging findings there. All of those would cause some combination of meningeal enhancement and/or hydrocephalus and/or small or large ring enhancing lesions, tuberculoma, cryptococcoma, and/or infarcts, because the basilar meningitis affects the vessels. So we're probably ultimately going to do a lumbar puncture to make a firm diagnosis here, whether that's filled with B cells that through flow cytometry match the patient's cancer, or whether we see an infectious profile and we're able to grow something or have antigen or PCR testing come back positive. So what did you find on the imaging, Valeria? Are we on the right track? Are we in for a big surprise that's going to shift the course in the last 2 minutes here and show how my time budgeting skills continue to be poor, as goes with the history of VMR, and we'll go over for another hour based on what you're going to show me?
No, you're right on track. I think I'm gonna give you just everything I got. But I think I mean you totally got the imaging right, but I think the LP may be a little bit of a discussion point. So
okay.
Yeah, as you totally got right. We got an MRI because our CT machine broke, so we had to decide a CT or an MRI to ask the family for. And so they got an MRI, and indeed it showed a lot of leptomeningeal enhancement. However, the LP that we got was a little confusing for us. So the CSF was transparent. We found 140 leukocytes. 65% were mononuclear. And there were 15 red blood cells, 51 proteins, and glucose was 20.
Can I ask you, Valeria? Oh, sorry, go ahead. Go ahead.
No. I was asking you, what do you think?
Leptomeningeal enhancement on the MRI, was there hydrocephalus or no?
No, there was just a diffuse cerebral edema.
Edema, okay. So we were pretty close there, and nothing else on the scan, just the leptomeningeal enhancement and cerebral edema. Fantastic. Yes. Oh, well, not fantastic for the patient, but fantastic for your concise summary of the imaging. And then do you have a serum glucose to go with that CSF glucose by chance? Or it's a low number, but if the serum is, the patient's also hypoglycemic, it might not be that low. Yeah. Okay, if you don't have that. Do you have a serum glucose or no?
Yeah, it was 96.
96. Okay, great. So just quickly, since we're past the end of the hour here, Joy, what do you make of this CSF? We're sort of down to trying to figure out now, is this an infection or involvement of the cancer? Does this profile lead you in any particular direction?
I not really, but I'm going to think that investigate for would think for infectious here, like the 140 leukocytes. Like what you said, fungal, definitely fungal with the chronicity of their presentation, and the 15 RBCs, that's within the range of normal. The glucose, 20 glucose, that I would think that's low, right? So could be usually that we would think of that as like a bacterial etiology. So I'm not sure. I'm thinking definitely infectious or inflammatory, something like that. Yeah.
Yeah. Excellent. So yeah, we see meningitis on the scan as we expected, but it doesn't tell us if it's infectious, inflammatory, neoplastic. And the CSF profile, so we tend to think of low glucose in bacterial, fungal, and tubercular meningitis, and low meaning usually less than 40 or less than, about less than 40 or 30% of the serum glucose. So this is quite low, but you can actually see low glucose in some viral infections. You can see it in leptomeningeal disease. You can even see it, I believe, in sarcoid, if I'm not mistaken. So all these things we learn in medical school, have their exceptions. The rest of the profile, what's interesting to me is if this was the patient's lymphoma, presumably we would have heard lymphocytes or atypical cells, and we're seeing monocytes here. Am I right, Valeria? Those are monocytes, the 65%, or? Oh,
no. They're just not PMNs.
They're not PMNs. I see. So we don't know if they're lymphocytes, monos, EOs, or otherwise. Okay. Okay, so it's a lymphocytic predominance with a hypoglycorrhea, low CSF glucose. As you said, this could be anything infectious, inflammatory, or neoplastic. And those could be the patient's cancer. I corrected, I said these are mononuclear, but not monocytes. That was my misreading. And this could be infectious also. And this is a common scenario we end up in. So what are the next tests you would be ordering, Mattia, to try to sort this out? And we're obviously trying to get to a diagnosis, but is there any treatment you would start while awaiting these tests coming back?
Well, it's complex. I mean, I would definitely want to start some kind of empiric therapy. I would have started empiric therapy in the ED. Now, whether this is sort of a mixed bag of NLP, so I don't know that I would stop my empiric therapy. I wouldn't. Now, in terms of where we are going with this, I definitely would want to see a flow. I would definitely want to have bacterial cultures. Given the high risk of this patient, having some kind of fungal etiology, I definitely want at the very least to know about Cryptococcus and other environmental fungi. I was also curious, what was the opening pressure on this patient?
I'm gonna guess high.
Sorry. Oh, it was 25.
Yeah.
It was not.
Yeah.
Terribly high.
Because of course, Cryptococcus can be associated with very high opening pressures. TB for sure. So an acid-fast stain, and then again, both flow and cytometry. I think those would be key to have. Because then again, with a low glucose and a lymphocyte predominance, I think fungi are still on the table here.
Absolutely. Yeah, excellent. So that's right. So we're going in our usual order here of, history exam, labs, imaging. But as Mattia said, as soon as you examine this patient, and maybe even over the phone while you're going to the ED, this is a treat first, ask questions later situation, because there's studies that show that if this is bacterial meningitis, for every hour you wait, the patient's going to do worse. And you're not changing your LP results. That's a myth. The biochemical and culture changes last probably days. So get your antibiotics going, get some blood cultures, because a lot of bacterial meningitis cases, the blood cultures will be positive also. I don't remember the exact percent, but I think well over 50% at least. So, right. And this patient's immunocompromised and over 50. So we'd be looking at vancomycin, ceftriaxone, ampicillin. Before you had the imaging, a lot of people would throw on acyclovir just in case this patient has HSV. Probably after that scan, you probably don't need the acyclovir anymore. But I agree, this would not be a typical bacterial profile or a bacterial course, but I think most people would be hesitant to stop antibiotics until we see cultures. So we do want bacterial cultures. We do want cytology, someone to actually look at the cells under the microscope and say, hey, these really are very atypical. This looks like lymphoma. And then flow cytometry, where actually they're measuring based on the CD profiles on the cell surface, what types of cells these are, in case they are lymphoma, although CSF studies are actually not that sensitive. And we say it takes up to 3 lumbar punctures to get into a reasonable sensitivity range to diagnose primary CNS lymphoma, although probably a little higher if it's invading the meninges as it is here. And then for infections, I agree, we're probably more in the fungal and TB category. So what are the most sensitive tests for crypto? It's actually the CRAG, or cryptococcal antigen. Fungal culture takes a long time to come back. What is called India ink here, though my colleagues in French-speaking countries say encre de Chine. So some places it's Chinese ink and some places it's India ink. I think, Valeria, you've told me before it's also ink of China in Spanish-speaking countries. Is that right? This is on the boards, but very insensitive. You really want that CRAG study, depending where you are in the world. If you're where I am in California, I'm learning that people are looking for coccidioides. So it's antigen antibody testing in the CSF. I haven't seen my first case yet, but I'm waiting for it. And then TB, again, we learn about acid fast and Zeal-Nielsen and culture. The diagnostics are very insensitive for TB. Culture is very sensitive, but takes a long time to come back. Acid fast, not very sensitive. So you really want the gene expert, which is a DNA PCR for TB, and even that is imperfect in its sensitivity. Is this so let's take our final votes. is this infectious or is this cancer? Just in one word, Mattia, and one word, Joy, and I'll go last so I get to hear what you think first. Infectious, cancer, or cancer?
I'll go with infectious. I guess it was my first thought. I guess I'm having a bad case of anchoring.
No, that's okay. Sometimes the anchor is in the right port. Yeah. And Joy, infectious or cancer?
Okay, so we'll just cover everything. So I would think cancer or something inflammatory.
Okay.
Yeah.
So a vote for infection and vote for cancer. It really could be either. I think I'm on the infectious side of the coin. I can't really give you a good reason for that. Maybe this is a little fast for leptomeningeal lymphoma, but maybe not. Your ICP is not elevated until it is, and then things can go down quickly. The glucose can be low in neoplastic invasion of the meninges, but it's really low compared to the serum there. It's not kind of on the border. But it could be anything. And if it is an infection, what infection is it? I don't think we could say without further data. Would we be, I don't know, Valeria spent a lot of time in the US recently doing rotations. I don't know where this case is from, if it's from Peru or from the US. If it's in a TB endemic area, I think it'd be hard for us not to start covering that if the patient's getting worse on bacterial treatment and we don't have data back yet. If not, would you add amphotericin and some of these very toxic antifungals while awaiting those tests? Probably depend on if the patient's getting worse in front of your eyes on just antibacterials. So where is this case from, Valeria?
From here, I said that our CT machine broke.
Your CT, yes, that was a clue, although this can happen and you still had an MRI, so I wasn't. So, well, in that case, I have my Valeria bias. She, I think, has presented several different versions of TB over the course of the years, but that's just morning report gamesmanship and not clinical reasoning. This could be either, and we'd be probably adding a lot of empiric stuff while we waited for our pathology lab to tell us what's going on here. So what came back positive? I'm gonna go with infection, and this feels a little fast for TB, but I don't know.
Would listeria present with this? Listeria is more abrupt, right?
I would. So I've actually never seen a case of listeria. Could do this. Yeah, I would think bacterial in general. The patient's not going to be still able to wake up enough to answer Valeria's questions with normal speech after 1 week. But I don't have a experiential illness script for listeria just because I haven't seen my own case. But yeah, feels a little bit. It's fast, but it's a little bit leisurely for bacterial for me, especially in someone with hardly any immune system to fight it. So I think if it's infectious as TB or fungal, and just going with a Bayesian approach, I'm gonna say TB. But tell us what you found, Valeria.
Okay. Yes, we were right there with you. Thinking this could be TB because of where we are, and the glucose really threw us off. We repeated the LP, but in the hospital we don't have the glucose reactant, so we couldn't get the repeat glucose, which was a shame. But it will stay the same. We did get a repeat gene expert, so gene expert negative 2 times, crypto antigen negative twice as well. Gram didn't show anything, sorry, and cultures didn't grow anything either. And then we got some PAP and cytology samples, but they were not very good. And pathology suggested flow cytometry and also the immunohistochemistry. So we did that, and flow cytometry showed phenotypic findings compatible with meningoencephalic infiltration by lymphoproliferative disorder, chronic B lymphoproliferative disorder. So yeah, that was
leptomeningeal lymphoma. Yeah.
Yes.
Yeah. So yeah, looking back, anything that would have led us to or from that versus infection. Sounds like you and your colleagues are in the same place as us. This is either infection or malignancy, and it's very hard to tell. The CSF profile by itself could really be either. Glucose is maybe a little low for, you might say, for neoplasm, but important teaching point here that you can see that, and that doesn't rule it out. The negative gene expert doesn't rule out TB, right, Valeria, who has a lot of experience with this. I think it's only 60 to 80% sensitive on the CSF or something. That's, or don't quote me on that, but it's not as nice, as good as we would hope it would be. But negative twice, I guess. And did you start TB therapy while awaiting all this pathology to come back, Valeria? Or just curious how you practiced there.
No, we started, as you said, empiric bacterial coverage as well as listeria coverage, and oncology started at acyclovir, but we weren't really sure if that was the best thing to do because I think acyclovir has some neurotoxicity properties or risks, or that's what the team mentioned.
Nephrotoxicity, I think, but yeah.
Okay, I might have to look that up. But no, we didn't start any anti-TB coverage. We were pretty convinced with low glucose that this could be TB, but just because it's a great commitment to start TB therapy, we waited, and the flow cytometry and the repeat LP were pretty quickly to come back, thankfully. So we had those answers. And some teaching points that I have about leptomeningeal carcinomatosis, please, just quickly, because we did learn a lot. It was my first case, and I think for some of the people in my team as well. So it's associated with some cancers like breast, lung, melanoma, and hematologic malignancies. And it can be a complication in up to 8% of solid tumors and up to 15% of hematological cancers, but it's still very rare. It can cause Bing-Neel syndrome, which is caused by, I believe, myeloproliferative, like it's a variant of multiple myeloma, Bing-Neel syndrome, when there's leptomeningeal carcinomatosis due to a variant of multiple myeloma, but it just has an eponym. And then it's a very, very bad prognosis. And what I learned that was really important on this case was that false negatives are really common, especially when the samples are refrigerated for 48 hours or more. And false negatives can happen up to 36% if this takes a while. So, to take that in mind, because it was a case of this patient, because we had to do the studies outside of the hospital, we didn't have the best conditions. So of course we did see some problems with the cytology at the beginning. And CSF studies usually show myelopyrocytosis, hypoglycemia, usually less than 60, and elevated protein, which was the case of this patient as well. So yeah, thank you for this amazing discussion.
Excellent teaching points. And Valeria, how did you treat this patient, and how did they do?
Yeah, so the patient is still with us in the hospital. Oncology started intrathecal chemotherapy. However, when we talk with them, this lymphoma has very bad prognosis. And I think what could have made a difference probably would have been to diagnose it earlier, because usually the time from the life expectancy when you are diagnosed with this cancer is usually 3 months. So this patient had a 3-month history of headache. So she's probably gonna pass away pretty soon, sadly. However, I think oncology didn't pick on this headache concern early on. And given the lymphoma and the type of lymphoma she had, I think this was something that could have changed maybe the course of the disease, because it was something that the family did say that was happening for a while. So yeah. She's now in palliative care.
I think for leptomeningeal spread from solid organ cancers, the prognosis is generally very poor. I'm actually not sure for lymphoma, because lymphoma can be very chemotherapy responsive, but once it's to this stage, I'm actually not sure the prognosis if treated with intrathecal chemotherapy and otherwise. But excellent teaching points. Well, excellent discussion. We learned a lot. My mentor, Marty Samuel's aphorism that neurology of cancer, the differential diagnosis is the cancer, in the first few spaces, ended up ringing true here, even though we had to obviously strongly consider other potential etiologies. And very important, as Valeria mentioned, that a lot of these studies for some of the infections are not perfectly sensitive. And then cytology and flow cytometry, unfortunately, also not very sensitive. As I mentioned, it's usually considered you need 3 large volume lumbar punctures to diagnose primary CNS lymphoma. And I've seen cases where even you don't diagnose it based on those, and patient ends up needing a brain biopsy. There's a nice paper from my colleagues at UCSF in JAMA Neurology, probably, I think it came out when I was a resident, so 2012-ish, on the sensitivity and specificity of studies for primary CNS lymphoma, including things like beta-2, microglobulin, and the data around these, how many LPs you need to try to make a diagnosis before you have to move on to other steps. So that could be worth looking at for people interested in this. Probably about 10 years ago in JAMA Neurology, a review of diagnostics for primary CNS lymphoma in general, not specifically leptomeningeal. Excellent. Okay, well, thanks for bringing this case. Thanks for indulging me running way over. Thanks to our interesting discussion of this case with Mattia and Joy. For those of you who are still with us, pretty good yield, 20 out of 26, I think, originals. Thank you for sticking with us. Leah, do you want to tell us your teaching points?
Yes, I will just capture a few or choose a few teaching points from this discussion. So we started by discussing headache and altered mental status. And what I think was very interesting and important was to differentiate between altered mental status as the level and the content of consciousness. So how conscious or what's the level of arousal of the patient? Are there any signs of somnolence, or is it maybe more a question of the patient is not very attentive, and that's why we call it altered mental status. And then we also talked about what you can think of when you have neurologic symptoms and cancer in the history. You can think of either direct causes, treatment-associated complications, and also paraneoplastic syndromes. And we discussed a bit about CSF testing. So it's quite helpful and important to know how the tests are sensitive or useful. So probably it's a good thing to inform yourself about what kind of tests you send before you send them, and then also when you interpret them, whether you can really take that as a negative or might need to do some other testing or consider something else as well. And the final diagnosis was leptomeningeal carcinomatosis, which is most common in breast, lung, melanoma, and heme cancers. And it can complicate solid cancer courses in up to 8% and up to 15% in heme cancers. And also in this case, the CSF is typically has high protein and low glucose. So something that we might also associate with bacterial infections. And yeah, that was a short summary. Thank you for sticking until here, and I hope you have a great day.
Thank you very much, Leah, for tracking and summarizing those teaching points. Thanks again, Valeria, for bringing us this very instructional case. We all learned a lot from the case and from your presentation. And Joy and Mattia, thanks again for your discussions. We all learned a lot from those as well. And we will do this again sometime soon. For those celebrating the holiday this week, please have a nice holiday. For those recovering from COVID, hope you feel better soon, and everyone else stay safe out there. Have a good day / night, everyone. Take care.
Thanks, Valeria, for sharing the case.
Thank you. Thank you for the case.
Amazing discussion.